Hi, everybody. Very nice to be with you here today. So I'm excited to talk to you about the Quality Payment Program. I think we have about an hour or so. I do have a fair number of slides. I'm going to try to get through them, giving you enough information, but quickly enough that we have some time left for questions. Certainly, this is one of the biggest changes to the Medicare program in many, many years. Certainly the biggest change to physician payment practically since the 1965 law was passed authorizing Medicare. We have spent an enormous amount of time over the last really year or more engaging with, in particular, the clinician community to get their feedback on how, So I'm going to do my best to at least get started. It's certainly better with slides, so you have something to look at, but I can certainly speak to it. I've got it in front of me, so I know what I'm talking about. I think it's a projector problem. In any case, I do want you all to know that this proposed regulation, but in particular what we finalized for the program, that I'm sure you all have been reading about, really significantly reflected what we heard from our stakeholders, in particular the clinician community. We, of course, spent a lot of time with patients and families as well. That's how we do business at CMS. We really go out into the field, get out of our offices, go into physician offices, see what the pain points are for clinicians, and that really informs our policies. So what I want to do first is sort of set the context for you of where we were coming from generally, sort of the high-level context around payment reform. Then I'm going to talk in more detail about the Quality Payment Program, and then talk a little bit about the help that we have available for folks. Oh, there we go. What do you know? The help that we have available for folks such as yourselves and all clinicians to understand how to be successful in the program. I don't know how many of you are familiar with the goals that Secretary Burwell set in January of 2015 for how we transition our payment system really under Medicare, but this was really intended to be in partnership with states and commercial payers. So it's really transforming to paying for volume, so paying for number of services provided, to paying for values, to paying for high-value care, high-quality care, at lower cost. So we really think there's three things we've got to focus on in order to transform how we deliver care in this country. Number one, we have to change the financial incentives. That is what MACRA seeks to do, as well as other programs that are out there for hospitals and post-acute care settings, dialysis facilities, and so forth. So that's number one. Number two, we have to incentivize the right kind of care delivery. So incentivizing things that you all know and care a lot about, like care coordination, engagement of patients, shared decision-making, coordination of care across different types of care like behavioral health and clinical health. And then finally, and I think this is a foundational pillar of how we transform care, is distribution of information. And what we mean by that is really two things. First of all, allowing clinicians or helping clinicians to have the information that they need at the point of care as they're caring for patients. So having information, ideally through their electronic health records, we know we have not reached this nirvana yet, about their own performance, about where there are gaps in the care that are being delivered. So that rapid cycle feedback of quality information and utilization information as well. So that's number one. Number two is making information about performance and about cost transparent. We know that gives consumers more of a choice about where to seek their care, and we're actually seeing more and more over the last several years, patients and consumers getting really engaged in understanding the quality landscape and understanding how to make choices, but also really important to help drive improvement as well. A few years ago, my boss, Patrick Conway, and the administrator at the time, Marilyn Tavener, published, we'll try to get that back, published an article in JAMA that sought to lay out sort of a framework for this transition to value-based care. And so they identified 4 categories of payment. These are very broad categories. There's probably about 7 or 8 categories, but they identified 4 to make it a little simpler, to identify how we would transition from, again, our current fee-for-service paying for volume system to a fully paying for value system. So category 1, fee-for-service, no link to quality at all. And fortunately now, payments through the Medicare program that are purely fee-for-service with no link to quality are about 10%, so at an all-time low. Category 2 is fee-for-service, but with some link to quality. And we think of this as sort of our pay-for-reporting, or even some of our pay-for-performance programs that you're familiar with, like the Physician Quality Reporting System, the Physician Value Modifier, the Readmissions Reduction Program for hospitals. Category 3 starts to get us into the alternative payment model space, where it's not just pure fee-for-service with a multiplier up or down based upon performance on quality measures. But you're talking here things like the Shared Savings Program, or ACOs, bundled payments. So for example, the CJR program, which is the Joint Replacement Bundled Payment Program for hospitals. However, payments are still triggered by delivery of services, but there's an opportunity for shared savings and sometimes even two-sided risk, up or downward risk. Think of this as the Shared Savings Program, again, bundled payments, the Comprehensive Primary Care Initiative, and so forth. Category 4 really gets you to risk-adjusted, population-based payments, where clinicians or health systems are paid. You can sort of think of it as a lump sum for the care of their population of payments, with target prices typically set based upon historical benchmarks. We see this in the Maryland hospital system. Vermont just announced an all-payer system there as well. And some of the pioneer accountable care organizations and NextGen, they're really sort of based upon this idea of population-based payments. So clinicians and organizations are paid, their payment is not triggered by a particular service. So volume is really not linked to payment at all. I have this great slide that you can't see that shows that we set two main goals for ourselves, but we asked commercial payers and states, well now my computer, oh there we go. And now states to also share in these goals. The first goal was that by the end of 2016, that through the Medicare program, 30% of our payments through Medicare would be linked to quality and value in some fashion, through alternative payment models. So that category 3 and 4, shared savings program, population-based payments, bundled payments, et cetera. And that by the end of 2018, that a full 50% of payments would be linked to quality and value in some fashion, in that fashion, through alternative payment models. We actually met our first goal at the end of January of this year. So we're at about, I want to say, 32 to 33% of payments coming through alternative payment models. And we think that we can reach our goal in 2018, here we go, especially with the advent of the MACRA, or Quality Payment Program. And we did this to really set internal goals for ourselves. I don't know how many of you are familiar with SMART aims and SMART goals, but really in order to set a goal with a timeline that we thought was achievable, we felt was really important to really drive change. And we invited, in particular, commercial payers, but also states to share in these goals, which I will tell you that community has been extremely enthusiastic about sharing in these exact same goals and moving to accountable care and population-based payments. There are many commercial payers out there that are doing the exact same things that we are, in some states even ahead of where we have been, but that has been very exciting as well. All right, I'm going to now talk to you about the Quality Payment Program. So our thinking about the Quality Payment Program was really under this broader context of how we shift to paying for volume with those three tenets around financial incentives, care delivery, and distribution of information that I talked about. So the Quality Payment Program, as I mentioned, is going to reform Medicare Part B payments. It's going to affect approximately 600,000 clinicians across the country. That number may seem small because you all may know there's 1.3 million clinicians in the country. The first 2 years of the program, only certain clinicians are subject to the program. Starting in year 3, additional clinicians will be subject to the program. Clinicians essentially will be able to choose how they want to participate. It's probably not a full choice, depending upon whether or not you work for a healthcare system or you work independently, but essentially people will be in one of two tracks. One is what we call advanced alternative payment models. I'll talk more about that in a moment. If you are part of an advanced alternative payment model, key here is that you're taking some downside risk as required under the legislation, that you will also receive an additional incentive, a 5% lump sum bonus for participating in that advanced APM. Or you may participate in the merit-based incentive payment system, which essentially consolidates the 3 existing programs of PQRS, value modifier, and meaningful use. And I'll, again, go over that in more detail. So you all, I'm sure, are familiar with the unsustainable sustainable growth rate, in which for many years, this was established in 1997, that if overall physician costs were greater than target Medicare expenditures, this is obviously highly simplified, then physician payments or clinician payments would have been cut across the board to clinicians who billed Medicare Part B. And every year there was a temporary doc fix, except for like the first couple of years, in order to avert some pretty substantial cuts. And so nobody ever really felt those cuts because, again, there was a doc fix every year. But this clearly was an unsustainable path. Only took 18 years to fix it. All right, who participates? So who participates in MIPS? We're going to start with MIPS. So one of the things the law allowed us to do, which we did not have the flexibility to do under our other programs, our former programs, was to establish what's called a low volume threshold. And I actually participated in giving a lot of technical assistance to congressional staff during the development of MACRA for about a year and a half prior to its passage. And one of the things that we and many others said was, you know, there's a lot of clinicians out there who are getting pay cuts through CMS who really don't see very many Medicare patients. And so it's not worth their while to participate in our program, so why should we penalize them for that? And so I think, and many, of course, you know, physician and other clinician societies felt the same way, so they allowed us to establish a low volume threshold. So what we established, and this was really based directly on public comment that we got many, many comments to go exactly in this direction you see here, which is that clinicians who bill more than $30,000 a year and provide care for more than 100 Medicare patients a year would be subject to MIPS. So if you bill less than $30,000 or fewer than 100 patients a year, you are not subject to MIPS. So these clinicians in the first year, again, this is written out in the statute, is physicians, physician assistants, nurse practitioners, clinical nurse specialists, and nurse anesthetists. We will be able to add other clinicians starting in year 3, like physical therapists, speech therapists, and so forth, who actually, by the way, are subject to PQRS now. But there's 3 main categories of clinicians who are excluded from MIPS. These include newly enrolled Medicare clinicians. So you're right out of residency in your first year of billing Medicare, or you have been practicing and haven't been billing Medicare and you decide to join the Medicare program, you are not subject to MIPS in the first year. Again, as I just mentioned, clinicians who fall below the low volume threshold, and then clinicians significantly participating in advanced APMs. And what we mean by significantly participating is actually very clearly defined in the statute. And that says that if you're a clinician and you participate, you are part of an advanced APM, let's just say for sake of argument, Track 3 ACO or Next Gen ACO, that 25% or more of your reimbursement from Medicare has to come through that ACO. So it's actually a fairly high threshold. We also established a patient percentage threshold in our final rule, which I believe is 20%. Oops. Oh, I'm sorry, I'm getting confused on mine. Okay. All right. So I think the biggest change that we made between the proposed regulation and the final regulation was really based upon the overwhelming feedback that we received that people really felt they weren't ready, particularly for the MIPS program, but also not ready to join advanced APMs by the time the program was proposed to begin, which is in 2017. Even people who had been participating in PQRS and meaningful use felt like they really needed more time to understand the program, because while in many ways things are simplified by combining the 3 programs, at the same time there is more complexity in some other ways in terms of the choices you have about joining advanced APMs, the scoring methodology, there's a new category of improvement activities. What does that all mean? People really felt like, if we're going to finalize our regulation in October or November and it starts in January, that just wasn't enough time. We heard from others that who had been participating that they were ready to start in 2017, however. In particular, large group practices, people who'd been participating in the program for years felt like they were ready in 2017 and didn't want to delay. And so, we had this really broad variation in input that we got, and we wanted to be able to allay some of the anxiety that people were feeling while giving people who had been participating an opportunity to be successful. And so a few weeks before we finalized our regulation, we started talking about something called Pick Your Pace. And we are really thinking about the first year of the QPP as a transition year to help people get ready to be successful in subsequent years. And so we identified 4 general areas or 4 general ways to participate that people can really choose from and avoid a downward payment adjustment, avoid a payment penalty. We really felt like we needed to take the pressure off of clinicians in the first year, the financial pressure off of clinicians, and find ways for them to be able to participate without the risk of having a payment penalty. And so we introduced Pick Your Pace. So I'll walk through these. The first is if you want to just test. So this is really probably something that people who have not participated in our programs previously and don't fall below that low volume threshold, that if they really don't feel like they have their systems ready, they still are looking into purchasing an EHR, they want to collaborate with a registry, but they're not sure what registry is available to them, they've never submitted quality measures before, that if you just submit a very minimal amount of data to CMS, and this can literally be one measure, that we will not penalize you, right? You are not at risk in this first year of getting a downward payment adjustment if you just submit anything to us. And so we think that that will allow people who are currently not participating a little, some time to be able to figure out how they want to participate more in future years. The other thing, just as a backdrop, just to tell you, is that in the current programs, about 62% of all clinicians who bill Medicare participate in the PQRS program, and about 74% of clinicians participate in the Meaningful Use program. So participation is already, it's grown dramatically over the last 3 to 4 years. But there's still, a fair number of folks out there who haven't been participating or just started and are just feeling really uncertain. The next thing we talked about is partial participation. Now, I do want to start off by saying, so we have partial participation, which is submitting 90 days of data, and full participation, which is a year, okay? There's nothing inherent about submitting 90 days of data that will get you a lower score than submitting a year's worth of data. We've realized after we released this that people have interpreted this to mean that if I submit 90 days, I can't possibly do as well as if I submit a year. And that's actually not the case. We don't score you differently if you submit 90 days. But we were suggested 90 days as a way for people to have a little bit more meaningful participation, mainly because people are familiar with the 90 days construct because of meaningful use, and have actually often asked for 90 days of quality measures as well. So we felt this is something folks are familiar with. It's a way for people to further test their systems, who maybe feel like they can do more than a single measure, maybe not quite ready for a full year. We have actually finalized a full year for the second year of the program, but this is a way for them to sort of ramp up. If you submit 90 days of data across the 3 categories of improvement activities, quality measures, and ACI, advancing care information, you could do just as well as somebody who submits a year's worth of data. We just know that people who submit 90 days may not have quite enough measures to be able to, because a lot of measures actually require a longer performance period inherent in the measure itself. And so we think that folks who submit 90 days certainly can still get a positive payment adjustment, get a small bonus, but on the whole, they may not do as well as folks who submit a full year, but at least they're not going to get a downward payment adjustment. Having said that, we think that there are people who submit 90 days who may be very high performers who could do well and get a higher incentive. And then full participation, again, 62% of clinicians are participating on a full year basis now, and we've actually lowered the requirements for what you have to do under MIPS. And so there could be a very moderate payment adjustment for folks who submit a full year, again, if they're high performers. And so, again, I want to just make really clear that positive adjustments are based on the performance data, on the performance information that's submitted, not on the amount of information that you submit. So we think that the best way, again, to get a maximum adjustment is to participate for a full year. Remember, under MIPS, one of the things that we did is we're incentivizing reporting of certain kinds of measures that we call high-value measures. These are outcome measures, safety measures, care coordination measures, appropriate use measures. You get bonus points for those kinds of measures. And for many of those measures, they actually span over more than a 90-day period. So if you're just doing 90 days, it would be tougher to select those measures. But you're not going to get penalized for not submitting those measures. And so the bottom line message is, in this first year, we are really encouraging clinicians to pick what is best for their practice to get them ready for 2018, when we expect it'll be a full year of reporting. There are 4 categories under MIPS. So remember, we have the quality category, which comes from PQRS. We have the cost category, which comes from the value modifier, which combined quality and cost. We have advancing care information, which is derived from the Meaningful Use program for Medicare. I do want to emphasize meaningful use for Medicaid and hospitals is still in place. And then we have the improvement activities category, which is new for us. So quality comprises 60% of the final score. We had proposed 50%. We finalized on 50 because we actually decided not to count the resource use category towards the score in the first year. We are giving higher weight to these high priority measures that you see here. We also finalized a number of sets of specialty specific measures in which we worked with specialty societies, many of whom approached us directly, but we also had already been working with a number of these societies on what is the sort of core set of measures that is most relevant for their society. And so clinicians can actually just go to these core sets and pick them. So it just makes it easier for a cardiologist to go to the core set of measures and pick those. I don't think we have a core set of measures for podiatry, but we'd definitely be interested in working with your association to identify a core set that could be used in the program. We also, as in the value modifier program, the law actually requires that we include what's called population level measures in the program. So in the value modifier, we already had measures around readmissions for large group practices, as well as measures of ambulatory care sensitive hospitalizations or ED visits for ambulatory care sensitive conditions like asthma, COPD, CHF, that kind of thing. Obviously, those are only attributed to groups who have enough patients and have meet the reliability threshold. So we finalized just one of those, the readmission measure. The only difference here, for those of you who may work in group practices that participate in PQRS and the value modifier currently through what's called the G-Pro web interface or the CMS web interface, which is actually mostly primary care focused. That's really only used by groups of 25 or more and almost exclusively by groups of 100 or more. We still require reporting all of those measures, so they're not really subject to the pick your pace. But again, those do tend to be practices that have been participating for many, many years and are very familiar with the process for how to submit there. Advancing care information, we dramatically changed from meaningful use in order to significantly reduce the burden of what clinicians had to do, and to allow for flexibility for clinicians to choose ACI or meaningful use measures that are most meaningful for them and not have to report on every measure and not have to meet certain thresholds. The trade-off there was some complexity in the scoring. And that was actually a trade-off that we faced throughout the development of this regulation. We had an overarching principle of simplicity and flexibility, but the trade-offs there, especially when you get to flexibility, is adding complexity into the program. And so under advancing care information, we really focused on the measures that are focused on patient engagement and interoperability. We do allow in the scoring folks to choose the measures that are most meaningful to them. Now there is a core set of about 5 measures that are required, and the reason for that is because of the original legislation that was passed for meaningful use. In order to be counted as a meaningful user, there are certain things you have to report on by law. So we couldn't make those optional. E-prescribing is one, health information exchange is another, and I forget all of them, but they're very clearly laid out on our website. But you only have to report as much or little as you want on each of those measures. So there's no thresholds anymore. The thresholds are gone. There are 2 measure sets for reporting, and this is because there are 2 editions of certified EHR technology in play. There's the current 2014 edition that most of you probably have, if you have an EHR. And then through the ONC certification rule, we have the 2015 edition. This year business drives me a little bit nuts. The 2015 edition, which doesn't come into play until 2018. And so that is required in 2018. So because MIPS starts in 2017, we know some people are going to have the 2014 edition, some are going to have the 2015 edition, so there's slight differences in the measures there. Okay. And by the way, I'm going to give you resources to understand all of this a little bit better, and you can also have my slides, because I do understand that this is complicated. So clinicians who are participating as part of an APM will automatically receive a 50% score in this category, because as a requirement of APMs, you have to use certified EHR technology. If objectives and measures are not applicable to a clinician under this category, we will reassign the category weight to other performance categories. Remember that each of the 4 categories is weighted by law. So quality is 60%, advancing care information is 25%, and improvement activities are 15%. Those weights can change over time. We know that some clinicians just aren't able to use certified technology because there's a problem with the vendor, there's a problem in their area of having enough access to broadband, whatever it might be because of a natural disaster. We have a number of hardship exceptions that are available that people can still apply to, and they will therefore not get penalized. We are actually pretty we pretty much approve almost every hardship exception that comes in, and we'll be defining that process going forward. There are a number of hospital-based clinicians who participate in our programs. Of course, I myself am a hospitalist, and so I don't have a lot of control over the EHR that my hospital chooses to use. And so hospitalists and other facility-based clinicians have traditionally been exempt from meaningful use. I did the same thing here. But if hospitalists want to report under the advancing care information and can work with their hospital to be able to do that, we do allow for that to happen, but we don't require it. Okay, improvement activities. This is a new area for us. I think the genesis of this within the legislation was that I think Congress recognized that clinicians were reporting on quality measures, but doing a lot of improvement activities, some of which were really innovative, to improve care for their patients and to help them perform well on quality measures. And they felt like this is an activity that should be recognized. In fact, if you think about it, in clinical practice, a lot of what you're doing is related to really, direct intentional efforts to improve care for your patients. There's things like MOC and participating in, your specialty society's registry or improvement activities. So they felt like you should get credit for that as well. So what we did was we went out to, first of all, a variety of clinician societies to hear what they were doing or what they had available to their members. We also went out to a number of high-performing health organizations across the country. Think, Geisinger and ThedaCare and Virginia Mason and actually University of Utah does some amazing stuff. And we went out to these organizations and said, what are you doing? What are some activities that you're doing that you've shown actually improve the quality of care and outcomes for your patients? The law laid out 6 very general categories of improvement activities like shared decision-making, patient safety, care coordination, improved access to care, but gave us a lot of flexibility in what we could define as an improvement activity. So we actually proposed about 96 improvement activities after getting feedback from all of these different organizations and clinician communities. And we finalized the vast majority of them. There's more information that's going to be coming about the details of this. I think the challenge for us at CMS was how do we have clinicians tell us what their improvement activity is? How do we measure that? Because it's not like quality measures where there's like a clearly defined process for how you develop and report. So for this activity, basically we're asking clinicians to just attest to us that they are participating in these improvement activities. But we have a really broad scope of improvement activities that we think, from the feedback we've gotten, the vast majority of clinicians will be able to attest that they are participating in. So right now, this category is weighted at 15%, which is the lowest weighted category. And I think Congress did that. That's actually laid out in the statute. I think Congress did that just because it's new, and we have to sort of learn as we implement this as to what's meaningful. How do you actually detect variation in this particular category? And so we do have the flexibility, though, over the years to be able to increase the weight of this category over time. And this is one that my personal feeling is that as we learn from it, I think it's so important that we really should be able to upweight this category over time. We also have the flexibility, by the way, to downweight advancing care information, not any lower than 15%, but we can go down to 15% once 75% of clinicians are, quote, meaningful users. And we're close to that. So for this first transition year, what does testing mean for an improvement activity? You can essentially attest to a single improvement activity. We sort of weighted those activities as high or medium. The vast majority are medium because I don't think we have a lot of evidence yet as to what is a highly valued improvement activity, so we'll learn that over time. Full participation means getting up to 40 points, essentially. And every medium activity is worth 10 points, and every high activity is worth 20. So 2 high-weighted activities will get you 40 points, 1 high and 2 medium, or 4 medium, which get you 40 points for a full score there. We do have a number of flexibilities for the improvement activities. For example, within the legislation, Congress recognized that some of these things are just harder for clinicians in rural and small practices. And those of you who paid attention to our rollout and all of our communications and all of the, my boss, Andy Slavitt, the administrator of CMS, is on Twitter daily. So if you follow, you should follow him. He's hilarious. He's wonderful. But he talks a lot about the burdens to small practices. He's very, very focused on that. Secretary Burwell, who is from West Virginia, is very, very focused on the small practices and rural practices and access to care. So that really also guided a lot of our policy making here. So if you are in a group practice with fewer 15 participants, or you're what we call non-patient facing clinicians, so think radiology, pathology, and so forth, you only have to attest to 2 activities, so you can actually, instead of the 4, or 1 high-weighted activity. Clinicians who are in certified patient-centered medical homes or an APM designated medical home model, you will automatically earn full credit under this category, because fundamental to a patient-centered medical home and fundamental to all of the advanced payment models out there, or alternative payment models, are improvement activities. We also have something we call the scoring standard, which is for those who are in APMs but they're not advanced APMs. How are we going to score you for MIPS? We had an overarching principle that if you were participating in ACO Track 1 and you're already reporting measures for that, we shouldn't make you report something else for MIPS. Those measures that you report and the way that you are held accountable for cost and the improvement activities that you're doing should count for MIPS. We're not going to make you do something additional. So we developed something called the APM scoring standard. So again, if you are in an APM, you will be assigned essentially full credit for this category, and you don't have to do anything else. So the cost category, we decided this year, based upon the feedback that we got, that we were going to weight cost, we also call it resource use, at 0% for this first year. And by the way, cost measures are calculated purely based upon claims. There's no reporting requirement for clinicians. And the reason that we did this, we actually proposed the 4 or 5 measures that are currently in the physician value modifier program, which are total per capita cost, Medicare spending per beneficiary, which is attributed to hospital-based clinicians mostly, and then total per capita cost measures for about 3 conditions. I think it's COPD, CHF, and maybe diabetes. I can't remember for sure. Those are in the programs now. However, 2015 performance year, which impacts 2017 payment, is the first year that all clinicians were in for the value modifier, the pay for performance program, the legacy pay for performance program. And so that significantly increased the number of clinicians who were subject to these cost measures. And what we heard was that people really did not understand these measures. They didn't understand how they worked. They didn't really understand the feedback reports we were giving them on how we actually attributed patients to them, how the measures were constructed. And so it felt very daunting, even at a low weight of 10 or 15%, I think we proposed 10% for this category, to be held accountable for cost when it was something they just completely didn't understand. So we heard that. We also had proposed a number of episode-based payment measures that are based upon, say, episodes of care for AMI, for joint replacement, that kind of thing. So we said that makes sense. This is new. We need to help people understand this. And so we said, okay, we'll weight it at 0%. In this first year. By law, by year 3, they have to be weighted at 30%. So they will be weighted higher than 0 next year, somewhere between 0 and 30, because by year 3, we have to weight them at 30%. One of the things that we've also heard a lot about this category, and even though nobody's subject to it this first year, I think it's important to talk about, people are very concerned that they see incredibly sick patients who have a lot of complications, who have difficulty accessing health care, and they are worried about being held accountable for these highly complex patients. And I know in your profession that is also the case for your patients with diabetes who have, obviously very severe wound infections and a lot of, comorbidities. And we understand that. So there's a few things that we did when we constructed the measures, but that we also did in the value modifier program that we are definitely on the table for this category once we do implement it. So first of all, when we construct the measures, you should know that we, for measures for a particular field, let's say for podiatry or for cardiology or what have you, we work very, very closely with the specialty societies to ensure we get all the right codes in there, that we're including the codes we should include, that we should, not including ones that don't make sense for them, right? So we engage very, very closely with the specialty societies and frontline clinicians of that specialty in construction of the measures. That's number one. Number two, these measures are risk adjusted for clinical comorbidities and for age. And so that's been really important as well. So they're risk adjusted for basically, almost any clinical comorbidity that a patient could have. So that's number two. Number three is that the way we've designed the scoring methodology is that clinicians are compared to one another within their field. So as a high procedure field, for example, you would not be compared to a primary care doctor. You would be compared on cost to the clinicians in your field who are subject to the same measure. We've heard a lot of concerns from, in particular, high procedure fields. They worry about being compared to primary care doctors who, of course, are going to have lower costs than an interventionalist, for example. But that's actually not the case. We do compare like to like. Having said all of that, I've been in the measure development world for a few years now, and cost measures are just not as sophisticated and advanced as quality measures. They haven't been around as long. I think there's still a lot of measure science that needs to be developed around things like attribution, for example. A lot of that work is going on. So I think Congress recognized that as well when they wrote the law, which is why it allowed for downweighting of this category in the first 2 years to give more time for that science to develop, for measure development to happen. So I think that's important. The other thing you see mentioned here, the QRURs, the Quality and Resource Use Reports. These are reports that we make available to clinicians. You have to go in and download them yourself from our website. What we have heard overwhelmingly is that these are kind of useless to people, just to be perfectly frank, that they can't understand them. They feel like sometimes the measures that are on there don't really reflect their care. So one of the things that we have been doing over the last several months in designing this program is we've brought in a number of people from the United States Digital Service, which actually is an arm of OMB, which I sort of think of them as these really amazingly smart young tech people, mostly IT people, but also they have a whole cohort of people who have experience in user-centered design. And so we've been adopting those skills into CMS. If you've gone to our website, you will see that our new website, when we launched the program, it's incredibly user-friendly. We've gotten tremendous feedback on this site. We did all of that with user-centered design. We literally sat down with frontline clinicians in their offices to show them prototypes of the website, and we changed things based upon their feedback. And so that's exactly the same thing we're going to be doing with these feedback reports, because the way they're designed now are just not meaningful to people. And so they will be completely redesigned with input from clinicians, because I think people like the idea of getting this feedback, but they just don't know what to do with it when they get it. So more to come on that, but I think this is an area that we have tremendous room for improvement. Again, cost performance category will not impact payment. However, we will be including payment information in those feedback reports I just mentioned, because in order to get ready for 2018, where a cost will be part of the program, we want to give people feedback early. So we will be doing that later in 2017. And again, no data submission required. We finalized this rule with comment. So what that means is that everything in the rule's final. All the policies are final. But there were certain areas we think there's still room for improvement. There are still things we could do differently. And we knew that people still had a lot to say about particular areas. One of these is, so those are listed here. I don't think this is every place that we sought comment, but we sought comment on a variety of different things. And so there's a 60-day comment period. It closes December 19th. I hope your organization is going to give us a comment letter on what your thoughts are on all of these different things. And then this will inform our rulemaking for 2017. Okay, alternative payment models. So APMs are, as you probably know, different approaches to paying for care and incentivizing high-value care. that have been around for a while. Most of the APMs that we're talking about here are ones that are developed and implemented through the Center for Medicare and Medicaid Innovation, or the Innovation Center. This was a center that was authorized under the Affordable Care Act to allow CMS the ability to test new models of care. And CMS and the Secretary do have the authority to expand these models of care to a national level if they are shown to improve quality while keeping costs the same or at lower costs. So very, very tied to quality and cost. So the law defines APMs as an innovation center model, the Medicare Shared Savings Program, or one of two different types of demonstrations that are really a lot less common. So we're really looking at innovation center models primarily. The law went on to further identify and define something that in the law is called an eligible APM. And so we renamed this an advanced APM to sort of more accurately reflect what it's supposed to do. And the advanced APMs enable docs and other clinicians to earn even greater rewards for taking on some financial risk related to their patient outcomes. I think what's very, very important to understand, if any of you or your colleagues are participating in an advanced APM now, is there's nothing about the law, there's nothing about the quality payment program that changes the design of any individual APM. It doesn't change the quality measures or how you're attributed, how you are assessed on cost or anything else of any individual APM. What it does instead is it provides very clear incentives, extra incentives, to participate more fully in an advanced APM. So you get the APM-specific rewards, as well as each individual doc who meets that threshold of 25% of payments coming through that advanced APM will get a 5% lump sum bonus just for participating. We defined the advanced APMs that are available in 2017. We certainly did get a lot of feedback that people felt like there wasn't a broad enough scope of APMs available in 2017. So we've been doing a lot of work to not only strengthen the current APMs, but also look at our other APMs that don't meet the criteria for being advanced. And see if we can retrofit them to become advanced APMs. So these are the ones that are currently in play that have been around that would qualify as an advanced APM. We will be updating the list of advanced APMs that are available on an ad hoc basis. Again, we do have the ability, though, to have more advanced APMs. So there's two pathways here to do that. The first is just through the Innovation Center Authority, to the way we've sort of been doing it, where either through input we get from the outside or our own ideas, we set up and implement an advanced APM. However, what Congress also did, in recognition of the fact that there aren't a lot of specialty-focused APMs in particular, and a lot of our APMs are more health system-based as opposed to purely clinician-based, they set up a mechanism called the Physician-Focused Payment Model Technical Advisory Committee, we say PTAC, much easier, in order to take in ideas from the probably mostly be the clinician world, but others as well, for new payment models that are really focused on the care that clinicians provide. So it says the word physician. This is really applicable, though, to all clinicians who bill Medicare Part B. So for 2018, we anticipate that there will be at least 4 new models that will be available. So we announced something called ACO Track 1 Plus. What we heard from commenters was that a lot of them felt like they weren't ready to take on the risk for tracks 2 and 3, and there's very few in track 2, but there's a lot in track 3 and next gen ACO. But we weren't able to actually make track 1 an advanced APM because there is a requirement in the law around downside financial risk, which is just not part of track 1 ACO. And so we are looking at something we call Track 1 Plus, which will be somewhere between Track 1 and Track 2, that includes some downside risk, but probably not as much as you're seeing in Tracks 2 and 3. And we'll have some other features as well that I think we've been hearing from folks that they want to see through the Shared Savings Program. We're looking at new voluntary bundled payment models, as well as retrofitting our comprehensive care for joint replacement model, which is attributed primarily at the hospital level, but does allow for gain sharing by clinicians. And then we've put out a proposal earlier this year around other mandatory models around cardiac care, as well as hip fracture, because the first one, the comprehensive care for joint replacement, is just about hip replacement as well as knee replacement. And so these rules are going to be finalized soon, and we're looking at how we can sort of retrofit those to be advanced alternative payment models. The main thing for those two models, by the way, that makes them not advanced APMs right now is that they don't require the use of certified EHR technology. And that is a requirement under the law to be an advanced APM. It's downside financial risk, use of quality measures to assess outcomes, and use of certified EHR technology. And neither of those currently requires the use of certified EHR technology. That has to be built in order for it to be an advanced APM. So again, what are the benefits of participating in advanced APM? You'd be excluded from MIPS, receive a 5% lump sum bonus, and starting in 2026, you get a higher update to the physician fee schedule than people who are not part of an advanced APM. Now, I think there just is this reality because of the availability of advanced APMs and people's readiness within their practice to be able to take on downside financial risk, that the vast majority of clinicians in the first year are going to be subject to MIPS. We think that probably somewhere between 90 and 120,000 clinicians who are eligible for the quality payment program will be in advanced APMs in 2017. So that's actually not a tiny number. However, the majority are going to be in 2017 subject to MIPS, we believe, because either they're just not in an APM, they're in an advanced or they're in a non-advanced APM, or they're in an advanced APM like NextGen or Track 3, but they're not a qualified participant, meaning they have less than 25% of their reimbursement coming through that advanced APM. Again, we were very, very focused on small and rural practices. We do believe that small and rural practices are every bit as able to be successful as anybody else. In fact, so there was, when the proposed rule came out, there was the infamous Table 64 that some of you may have heard about. What's that? 78%. Oh, well, it was actually 87%. Yes, but you're right, you're close. So what that table very infamously showed was that 87% of clinicians in small practices, defined as I think fewer than either 10 or 15 clinicians, would fail MIPS, and that was sort of how it was broadcast, if you will. But what the nuance there that is critically important is that the reason it showed that is because that reflected people who just didn't participate at all in PQRS. And we know that about 47% of clinicians in small practices participate in PQRS, and more than that in meaningful use, but it's not as high as the total number. So that reflected people who just flat didn't participate, and by law, if you don't participate in PQRS or value modifier, you get a full downward adjustment. However, when we look at performance on quality measures, which is really the only way that we could assess this for MIPS, we couldn't really assess meaningful use because we've totally redesigned it, so it's comparing apples to oranges. But when we assessed it for quality measures, clinicians who are in small practices who did participate, who submitted quality data and met all the requirements, again, 47% of those clinicians do just as well or better overall than the large practices. And I don't think this is a surprise to anybody, right? So, if you participate, you will probably do just as well. You have the opportunity to do just as well as anybody else. However, we do know that there are greater barriers to participation for small and rural practices because of the resources that are required to do so. So again, this was a big reason why we provided an on-ramp through the Pick Your Pace program. We're also expanding opportunities for clinicians in these small practices to participate in advanced APMs like through CPC Plus. There's also the way we have defined participation in advanced APMs is really what we call a practice-based option, so total revenue as opposed to total cost. And then we also, the other thing the law did that was, I think, very important is the law actually provided $100 million for us to provide technical assistance. And what we mean by that is that, frontline, boots on the ground, in your office, assistance to help clinicians report their measures, understand the program, understand their data feedback, use their EHRs, et cetera, and help them transform their practices. That is directed specifically to small and rural practices and clinicians who practice in health professional shortage areas. So we are in our procurement phase of those awards. The law required that we put those contract options out for people who are already quality improvement experts, if you will. So QIOs, regional extension centers, regional quality collaboratives. So those are the folks who would be bidding on those awards. So we should have announcements about that soon. But again, a very clear focus on this, what I would call the sort of more vulnerable community of practice for these programs. We also established, part of what drove our decisions around establishing the low volume threshold that we did was, again, what we heard from folks about who were in small practices or who may or may not see that many Medicare patients and didn't want to have that risk on the table for them. We also reduced the requirements for improvement activities for folks who are in practice of 15 or fewer. And we also increased the ability for clinicians who practice at CAUs or rural health centers or FQHCs to qualify as in an advanced APM to get that 5% lump sum bonus. Okay. As our practice has been since really value-based purchasing, came on the scene at all, and most of that came through the Affordable Care Act with the advent of hospital value-based purchasing. We also have a value-based purchasing program for skilled nursing facilities, is that as we implement these programs where there's more at risk for clinicians and for other types of providers, that at the same time that we and others are providing, again, that frontline technical assistance to help people to be successful. One of the things that's been actually very successful about the hospital value-based purchasing program has been two things that we launched. Well, one has been around for a long time that you're familiar with, which is the QIO program. We really redesigned the QIO program a few years ago to be much more robust and impactful than I think it has been, in particular because we're transitioning into value-based purchasing world. But also the Partnership for Patients, which is a national quality improvement effort that has contributed to significant improvement in readmissions and hospital-acquired conditions. And again, a lot of that was done because of all of the payment penalty programs and value-based purchasing programs that were coming on board through the Affordable Care Act. And that was really, again, focused on hospitals. Now we have value-based purchasing focused on clinicians. So in addition to what Congress has basically allowed us to do with $100 million for small practices, last year we launched a program called the Transforming Clinical Practice Initiative, which is a $700 million program to provide technical assistance to practices across the country to help them transform and be ready to take on financial risk over time through advanced APM. So we have a number of ways that people can get help, and we have, of course, all of this on our website about how you can go to which particular type of assistance. We have the QIOs. The QIOs traditionally have not been focused on clinician practice. They've really been focused on hospitals and nursing homes primarily. But we actually wrote into their work over the last couple of years that they have to also provide assistance to clinicians. So these will cover primarily larger practices, large in this case meaning over 15, which isn't necessarily large, non-rural practices, and they do direct technical assistance in your office when you need it. They also do. They also have established a learning collaborative, which is essentially getting in particular regions or states or localities clinicians together to learn from one another about what works for improvement. They have a lot of very deep experience with the current programs, PQRS, meaningful use and value modifiers, so really understand the day-to-day mechanics of participating in these programs. We have TCPI, which covers 140,000 clinicians. It's a 4-year model test, but we sort of revamped it to provide support on QPP. This is really focused on large-scale transformation, so again, practices that are ready to move into a financial risk environment and are ready to take that on. So that's what they're really focused on. There are 5 phases of practice transformation to help them, and this again is over a 4-year period. Then we have what I just mentioned, which is what we call the QPP SIRS, which is focused on the small and rural. And then if you're part of an APM, an inherent part of an APM is a learning and action network. And so these are very specific to the CMMI models. They are communities of practice that get together to learn from one another about what each practice is doing to transform. And I will tell you, I actually spent some time in the Philadelphia CMS regional office a couple of weeks ago, talked to some folks at Einstein and Jefferson who are participating in the oncology care model. And that's a new model. They just started, and they've talked about how hard it is to transform. But one of the things that they love the most about it, they're both incredibly excited to be a part of the model, is that community of practice and those learning networks, because they are actually taking best practices from one another to learn exactly what they need to do to transform. Because transformation of your practice to take on financial risk and manage a population of patients is incredibly hard. So they are learning from one another how to do that. Just a little bit about TCPI. The 5 phases are listed here. I think very critically at the beginning, you got to set very clear, smart aims for what you want to do to improve your practice. So what you're trying to do to improve outcomes for your patients. A lot of times practices need help understanding how to use data to actually drive their care. And so that's another thing that we help with. Obviously achieving progress on the aims, so consistent tracking of how they're doing against those original aims. Setting benchmarks and helping people to achieve that benchmark status, and then essentially being able to thrive as they're being paid for the value of care that they provide. So we're really just in the first year of this, where we've been spending a lot of time recruiting practices. We've met all of our recruitment targets, and actually doing practice assessments so practices know where they are along the continuum of moving to taking on more financial risk. I'm just going to skip over that. Because I want to leave time for questions. We are also targeting funding here to some rural providers. So while the $100 million under the previous contracts that I mentioned is there as well, we know that there's some in rural practices who also do feel ready to make that transformation and start taking on financial risk. So we set a target that 20% of clinicians that we recruit here would be in rural areas as well. Okay. So I mentioned our website before. I encourage you all to visit this site. It will be continuously updated. It's qpp.cms.gov. This is the site that I told you about that we spent a lot of time doing user-centric design. We also developed the site. We've really transitioned within CMS to agile software development. So that means that we can be very nimble in updating information and updating the site based not just with new information, but even functionalities. Our goal over time is that this is sort of the one-stop shop that clinicians have to go to for everything at CMS, everything. Now, we're not there yet, but it will take some time to get there, because you all interface with CMS in a variety of different ways, not just for quality reporting. But that is ultimately the goal. On that site is a tab for education and tools, which gives you information about all of the technical assistance that I just talked to you about, and certainly also gives you links to all of the APM, the individual APM sites, if you want to explore those and see if they might be right for you. And I'm going to stop there, and I think we have about 15 minutes for questions. So thank you very much for your attention. I really appreciate it.
Thank you, Ms. Goodrich. I have a few questions also, and a little bit on terminology. You talk about the exemptions for small practices, and I did a look at, in Maryland, for instance, I think 20% of Maryland podiatrists will qualify for that exemption. However, it depends on the definition. You flip-flop a little bit between what's called billable charges versus allowed charges. And that makes a big difference. It's allowed charges.
It's allowed
charges. So
charges.
in the literature that goes out there, we need to know it's allowed charges. But let me ask one further on that and define allowed, because there's a difference between what is allowed and what is paid. And there's deductibles that go into the paid situation. And a lot of times that can make a big difference also in whether we will, or some people will or will qualify as an exemption. So, because if we look at sequester, the rule states is that you can only go by what is paid out. The government pays out to the practitioners when you evaluate where they stand in terms of some of these qualifications. A lot of times, so I think we need to understand, is allowed really paid, or is allowed?
Allowed is allowed.
Allowed.
It is allowed, yes.
Okay, all right.
And that's a question we've gotten before. We know there's been some confusion about that. And so, but that is the case. That is the answer. It is allowed charges.
And then the other question is, when will that start? Because a lot of people are in, who in the small already have penalties being put into effect. So what is allowed and what is paid is a big difference then already.
Yep. So remember, the first year of the payment effect of MIPS is 2019. Apologies if I didn't make that clear. Okay. It is 2019. That will be based upon performance in 2017, whether you do full year test 90 days.
Yeah.
But we know people need certainty before the year starts about, or as soon as possible anyway, about whether or not they would be exempt. So what we're doing is we are determining if people are exempt based upon their allowed charges from, I think it's going to be, it's not actually a calendar year, it's something, in order for us to be able to tell people ahead of time, I think we're doing it something like from September of 2015 to August of 2016. We're looking at your charges there. so that people can know ahead of time. Don't quote me on that because I don't remember the exact dates, but our goal is to let people know either before the beginning of 2017 or very early 2017 whether or not they are subject to MIPS.
And is there a go-to website for the application to be
Well, there's
exempt?
not an application. We look at your claims during that time, and we can actually calculate allowed charges based upon that.
Okay.
So we will be telling you whether or not you would be exempt based upon that time period.
I see. Next question I have has to do with the MSSPs, the shared savings programs. A lot of us are trying to decide who do we join: hospital groups, multi-specialty groups, single specialty groups. Right now, if I envision what you're doing here is that do you have data on the success of some of these pioneer ACOs, these other programs where you have MSSPs already in effect that have been able to reach cost savings or
Absolutely.
cost?
Yeah, I don't.
Sharon, where do we go to see if some of these people that are trying to recruit us are
Yep.
indeed successful and they're right?
That's a great question, yes. So we do have those data. We do make them publicly available. If you go to qpp.cms.gov, which is actually, you probably want that, not my information. If you go to that, and there's actually a tab for APMs, okay? And then you can link to every one of the APMs, our website, on every one APM, including Shared Savings Program.
Okay.
And then on the website for the Shared Savings Program are downloadable files on all of our results, essentially. Now what I don't know, and I'm happy to follow up with you afterwards, I can give you my card so you can follow up with me, is how you actually get the information on each individual ACO and how they did. We have that. It is available,
Sure.
but I just don't exactly know where to go to get it off the top of my head, so I'm happy to help you with that.
Yeah, we hear pioneer ACOs, for instance, some work, some don't. We hear some of the local multi-specialty groups have had $5 million in savings.
And
How
some
they
don't.
split it amongst themselves is a difference
That's
in the
right.
model, whether it goes to the primary cares or the specialists.
That's right.
In looking at your APMs, your alternate payment plans situations, when you're looking at single specialty providers, let's say an orthopedic group, a large orthopedic group, they pretty much know that bundled payments for knee replacements, hip replacements are there. But we as podiatrists don't have too many APMs at our disposal for
Right.
a single specialty to really take advantage of. So how does a single specialty big group formulate into some of these situations you're talking about if we have no APMs that are available?
Well, I think, so if you're a podiatrist and there's a couple of different ways now, but you're right. I think podiatry is one field where there are fewer currently available APMs. I think that's true. I think that's true for a lot of specialists, actually. So we know that a lot of podiatrists are part of ACOs, whether they're track 1 or track 3 or next gen. So that is certainly one mechanism. I think the potential downside there is that there's not really measures for podiatrists. You're really being measured as a whole on what is essentially primary care. Although we're thinking about how we can actually allow in more specialty measures. We've been asked by the specialty societies to do that. I would say that your organization should think about whether or not you want to either collaborate with another specialty or on your own work to develop a physician-focused payment model that could be specific to your specialty and bring that through either the PTAC that I mentioned or just straight to CMMI. I mean, that's still an avenue as well. So that may not be available to you in 2017 and depending on timing, may or may not be available in 2018. But that's the whole point of putting together the PTAC or under the legislation was to allow for specialty societies to be able to have input into how they wanted to be assessed.
Okay, thank you
Yep.
very much.
Thank you for the presentation. It's really appreciated. You mentioned about GPRO. So if you're participating in GPRO for 2016, in 2017, it requires the full 12 months. That was my understanding what you said?
If you're participating in the web interface mechanism of quality reporting, which people often call the GPRO web interface, GPRO means group practice reporting option. Group practices can report through the web interface, they can report through registries, they can report through EHR. So there's multiple mechanisms. So this really just applies just to the web interface. Yes, they have to still report on all 15 measures. Because of the way that works is we basically send the group practice a sample of their Medicare beneficiaries. And so it's purely based on Medicare. And then they report based upon that list of Medicare beneficiaries.
Okay. And then touching up on what Mark said about the orthopedic side where you have total hip and total knee APMs. Obviously in podiatry, our only total joint, we have a total first MTP joint. But the question goes to the place, whereas ours are not done in the hospital, they're mostly done in ASCs. So how can that be utilized as a potential APM for podiatry?
Oh yeah, I don't see why the site of service for that would matter for assessing podiatrists on their quality and cost of care. I think you could definitely, that's actually true, I think for a lot of the bundled, well, I assume it's a bundle, but let's just use that as an example. For a lot of the bundled payment models that we've been hearing about from specialty societies, a lot of the societies have already started developing these. Many of them include the work that's done within an ASC. So I think I'm not an expert on how all the billing and payment works across the different sites of service, but I don't see a reason why that couldn't work for podiatry, as I am certain it will work for the other specialties as well that use ASCs. The ophthalmologists, for example, are considering something like a bundle of bundles because they have a variety of different types of procedures, almost all of which are done at ASCs, and that's something I definitely think is possible.
And one more question was about, you said there's about $100 million available for small, rural, and underserved areas. So small is defined as under 15, is that what it is?
Yes.
And how will doctors go about accessing that information? You have to go to the website to try to get to that, or how do you say that doctors should go there to help to get those funds that are available?
Yep. So it's not available yet because we haven't made our contract awards yet. That's coming very soon. So certainly going to the website will be a key way to do that. Once we have our awardees, we will provide direct links to those awardees so that people will know where to go. There's going to be, though, a lot of outreach, I think, from local and state medical societies, specialty societies, and others to reach out to small practices and rural practitioners, partly because we know a lot of them just don't even know about the program. And so we need to reach out to them as well.
But it will be on the
Yes.
this
Yes,
link?
it will be.
Okay.
Yep.
Thank you, David. You asked one of my questions about the $100 million. Everybody wants to know about the $100 million. The other question I had, you mentioned that if you have 25% that is going through an alternative payment model, which is probably a PHO or IPA, which a lot of people are organized with PHOs or alternative payment models. But suppose you have less than that 25%, do you also have to report on your own in conjunction with the
So if you're part of an APM that's a CMMI, an Innovation Center model, right? So you'd have to be part of the Shared Savings Program. So it's not just being part of an IPA, it's actually being part of one of these here, right?
That's advocate system, yes.
Okay, let's say you're part of, actually these are the advanced ones. So let's say you're part of a Track 1 ACO, which is actually where most of the ACOs are, right? They're in Track 1. They're participating in Track 1, and they're subject to the quality measures, and subject to, they're accountable for total cost of care as well, right? And quality improvement activities and use of EHRs. So, no, you don't have to do anything different than what you're already doing. That was very deliberate on our part, is to not require people to double report. So if you're part of an APM that isn't an advanced APM, just do what you're doing.
Just do what you do, that sounds good. The other thing is you said you give credit for certain comorbidities and clinical comorbidities in age. One thing I did not hear you mention was like socioeconomic factors or healthcare disparities if you practice in the inner city with another type of patient population. So how do you get that patient population included?
So there's been a huge amount of public discourse on how we deal with accounting for vulnerable patients who are at social risk and reward providers who care for that vulnerable population of patients and not penalize them for caring for that vulnerable population of patients. It's a very serious subject.